Today's topic is on BIPOC, which stands for Black, Indigenous, People of Color Mental Health. We have stories, stigma, and support. Mental illness affects every community. Access to care does not yet. This hour is about narrowing the gap in Fayetteville, one story, one conversation, and one referral at a time. Feel free throughout this month to hashtag BIPOC mental health, hashtag story stigma support. This presentation to you is presented by the Mental Health Advisory Board, which I am on the advisory board. My name is Ashley, and this presentation is conducted by City Councilwoman and our chair, Dr. Glover. Alrighty, so why we are here tonight. Mental health is universal, but unfortunately, access to care is not. You will hear me say the word BIPOC throughout the presentation, but once again, it means Black, Indigenous, People of Color, the Mental Health Month, which July represents. Communities of color in the United States experience mental illness at roughly the same rate as everyone else, yet consistently receive care at lower rates. This gap is not about who wants help. It is about how easy or hard the system around us make it to receive the help. Tonight, we will look at both. So once again, we have the stories, we have the stigma, the support, and last but not least, the action. So when it comes to stories, there are lived experiences that make the numbers real and remind us that recovery is common. There's support, culturally responsive care, community-based support, and the specific numbers to call in Fayette County. The stigma, how public and personal and structural stigma keep people from seeking, and how each is changeable. And action, one step we can take before this webinar ends for yourself, a family member, or even a friend. Mental health is health, full stop. When we take care of our minds, we take care of our whole selves and each other. This is basically the premise of this hour. All right, next slide. All right, the month has a name and a story. We have B.B. Moore Campbell, as a teacher, author, and advocate, an American author and journalist who wrote openly about mental health at a time when such conversations in Black communities were nearly absent from public life. She co-founded the NAMI, Urban Los Angeles chapter, and gave a public language to the private struggle so many families carried alone. So NAMI stands for the National Alliance of Mental Illness. In June of 2008, Congress designated July as B.B. Moore Campbell National Minority Mental Health Awareness Month, also known as BIPOC Mental Health Month today. With these three goals is to improve access to treatment, raise public awareness, and honor her legacy. As she quoted, "Once my loved ones accepted the diagnosis, healing began for the entire family, but it took too long. It took years. Can't we, as a nation, begin to look at mental health illness with a compassion and a hunger to know more?" These are three goals this month if you haven't already done so. One is to improve access to mental health treatment and services for communities of color. Two is to increase the public awareness of mental health, mental illness in those same communities. And three is to honor B.B. Moore Campbell's legacy by continuing the work. All right, to kind of break the BIPOC down and why we also name specific communities, language is imperfect and evolves. Tonight we use BIPOC, which means Black, Indigenous, and other people of color, a shared framing of shared patterns. Whenever we can also name specific communities, such as the Black, Latino, Asian American, Pacific Islander, Native American, multiracial families. Each have distinct histories, strengths, and needs. What does it mean? As we mentioned, as a shared framing when the point is a pattern that affects many communities regarding BIPOC. The approach, or our approach, is being specific when we can. When the data or the story is about one community, we name that community. Black families, Latino youth, AAPI, authors, Native Indigenous adults. Our commitment with not for, we share the community leaders, researchers, advocates, and those communities have said publicly, we do not speak for everyone. So mental illness does not pick a specific community, but care does. Roughly 1 in 5 U.S. adults experience a mental illness every year, and the rate similar across racial and ethnic groups. The difference that matters show up later in who gets a diagnosis, who reaches a provider, who stays in care, and who recovers. Once again, 1 in 5 U.S. adults with a mental illness is given each year in a year. Similar prevalence across most racial and ethnic groups. The difference is the rates of diagnosis and treatment and follow-up care. And what's changeable is almost all of the gap is in the systems, not the people. We have a quote here that the illness is not the disparity. The disparity is what we, as a community and country, decide to put as the illness. This is a synthesis of the last 20 years of health equity research. And the resource from SAMHSA in 2002, the American Psychiatric Association. All right, next slide. All right, we have some percentages here that we would like to share on rates, the different rates of care, same underlying need. And in 2023, Kaiser Family Foundation survey among adults in fair or poor mental health, roughly 50% of white adults received treatment in the previous 3 years, compared with 39% of Black adults, 36% of Hispanic adults, and SAMHSA national data tells a similar story. Black adults are about 36% less likely than the U.S. adults overall to receive mental health treatment in the past year, and Hispanic adults are 28% less likely. Okay? So there's a difference. There's some differences as far as being able to have that care, as we mentioned, needing to bridge that gap within the community. Okay, next slide. All right, young people of color are telling us something, and we should listen. While overall youth suicide rates in the U.S. show a small decline in recent years, the picture is not uniform. Multiple communities have the opposite trend. The highest, American Indian, Alaska Native adolescents and adults have the highest suicide rate of any U.S. group. Second, leading cause of death ages 10 to 34 from American Indian and Alaska Native people. And rising, the youth suicide rates increase in the African American and Asian communities. According from the CDC, this is within 2018 and 2023. 10% rise in Hispanic suicide rates overall from 2018 to 2023. What has happened where communities have acted early? Youth serving programs led by people who look like young people they serve. School-based counselors of color, community mentors, culturally grounded curriculums constantly improve reach and outcomes. Early screening is primary care in school and catches distress before crisis. Being proactive is definitely necessity. All right, next slide. So who is at the other side of the table? Representation is not a preference. It is a treatment factor. As of 2019, roughly 84% of U.S. psychologists were white, while only about 3% were Black, 7% Hispanic, and 4% Asian. Similar patterns exist across social work, psychiatry, and counseling. The gap is not itself unjust intent. It is a legacy of who has had access to training and pipelines, but it changes who feels seen when they finally sit down for care. So that's definitely a gap there. When it comes to the workforce demographics, this is presented by the American Psychological Association from 2019 reference. Okay, we have 6 barriers that keep care out of reach and are being lowered. Each barrier below has a real solution somewhere in the country. The point of naming them is not a catalog what is wrong, but is to easier for our community to work on what is fixable here. 1, the cost and insurance. Higher rates of being uninsured and underinsured in some communities, sliding scale fee providers, and Medicaid expansion matters here. The language access. Care is the first language is care that lands. Bilingual providers and interpreter services help close a real gap. Third is trust, real history. From the Tuskegee study to modern day disparities has cost providers trust. Rebuilding takes time and effort. And fourth is cultural match. Providers who share and understands a client's context helps clients stay in care longer and reach better outcomes. 5 is the stigma. Different in every community, but always changeable. We can spend 3 slides on this later. Reach and distance. Most Georgia counties of mental health professional shortage areas, telehealth has begun to help. Next slide, please. All right, story, stigma, support, in that order. Statistics tell us the size of a problem. Stories move us to act on it. Every campaign that has shifted BIPOC mental health outcomes has one thing in common. It centers voices within the community telling their own stories. B.B. Moore Campbell did it. Michelle Obama did it. Dr. Joy Harden Bradford of Therapy of Black Girls has did it. Athletes like Kevin Love, Simon Plies, Naomi Osaka did it. And after all, the phone lines rang. The pattern, one voice, many phone calls. After public disclosures of trusted athletes and artists Crisis lines and therapy directories constantly report spikes in outreach from the same communities. Why it works. Permission travels. Hearing a person recognize name what you have been carrying along gives you permission to name it too. Alrighty. The public, personal, structural, each is fixable in a different way. Stigma is rarely one thing. Researchers describe 3 layers, and each responds to a different kind of action. Knowing which layer you are meeting helps you find what you need to do next. So 1 is the public stigma. What communities and media collectively say about mental health illness, shifted by visibility, trusted voices telling the story in public over and over. 2, self-stigma, the voice inside that says, I should be able to handle this, shifted by naming and normalizing. Hearing others describe the same voice out loud. And 3 is structural stigma, the way systems such as insurance, schools, workplace, and courts treat mental health as second class shift by policy and design. Parity laws, screenings in primary care, education assistance programs, EAPs, and funded community programs. Next slide. All right, so this is a starting point, but not just a summary. Communities have named these patterns for themselves. No slide can capture any community. What we have here in this presentation is a few patterns that leaders, clinicians, advocates from within these communities have publicly named as worth understanding alongside the deep strengths each brings to healing. Read them in the invitations to learn more, not just conclusion, but I will read them for you. So among the Black and African American communities, the strength and collective care, weight of history. The strengths is deep traditions of family when it comes to church and communal support. Some name patterns, the strong Black woman, the strong Black man narratives are discouraged, asking for help. Historical medical mistrust is real and earned. The bridge, Black-led therapy directories, church-based mental health programs are growing fast. Within the Asian American Pacific Islander, the model minority myth compounds silence. The strength, strong intergenerational values and educational networks. The name pattern, the model minority myth pressures individuals to appear fine and hides real distress. Mental illness can be experienced as shame on the family. Within the Asian American and Pacific Islander, to help to bridge the gap would be those specific therapists that have directories and community programs led by the Asian American and Pacific Islander clinician. So within the Latin population, feminismo as a resource and sometimes a wall. Feminismo, family as first support, is a genuine protective factor. A name pattern, and excuse me if my Spanish may be off, as it says, no se saca la ropa sucia a la cala. It means do not air the family laundry. Can delay reaching outside help. Language access remains a real barrier. So how to bridge this gap is to continue to have bilingual therapists and Spanish language crisis lines. And then we have the Native American and Indigenous. Historical trauma is a clinical concept healing is ancestral. Some of the strengths is the ceremony, elders, traditional healing practices have supported wellness for generations. Some named pattern, historical trauma from boarding schools and displacement continues to shape today's health outcomes. Ways to bridge this gap is to have the tribal health programs and services rooted in Indigenous knowledge. Once again, this is not a fix-all to end all, but is ways to help bridge those gaps within each community by being able to understand first the community that you're servicing and each other. All right, the playbook is short and repeatable. Across communities, 4 ingredients keep showing up in outreach and measurably increases help seeking. And these are trusted messengers, meet people where they are, first language, first culture, and lastly, small and doable next steps. All right, regarding trusted messengers, it could be from pastors, coaches, hairstylists, athletes, people already listen to, not strangers with a pamphlet. Meeting people where they are, whether it's the barbershop talk, health talks, community center screenings, faith-based mental health first aid, bring the care to the room. First language and first culture, we have the materials, phone lines, providers who speak the languages and to understand the cultures at play locally. And regarding the next steps, not get therapy instead of text this line, attend this hour-long group, screen at your next physical. All right, the care that keeps people in care needs to be culturally responsive. Is not a nice to have, it is a treatment factor. Research is consistent. BIPOC individuals are up to 5 times more likely than white peers to leave therapy prematurely and more likely to repeat treatment as ineffective. Culturally responsive care, providers trained to understand cultural context, communication styles, lived experiences, measurable increases trust, retention, and outcomes. So, what is it? It's trained to see the whole person. A provider training is culturally, humility, language, migration, history, faith, and family dynamics, then applied in every session. And why it works. You have fewer dropouts, better outcomes. Studies show stronger therapeutic alliance has higher session attendance and measurably better symptom improvements. How to find it? By the community-run directories, such as Therapy for Black Girls, Therapy for Black Men, Latinx Therapy, Asian Mental Health Collective, Inclusive Therapists, and Nominees Sharing Hope program all curate providers. If anyone knows of any other groups, feel free to put that in the chat as well. Faith, family, and community are not backup, they are foundation. In many BIPOC families, the first and often most trusted place is to bring hard feelings is not a clinic, it is a pastor, and a abuela, a tia, a uncle, a coach, a community leader, a group that meets on Wednesday nights, care systems that partner with these roots instead of trying to replace them, reach more people and hold them together. We have the faith communities, elders and families, community and elder healers, school and youth workers. These are all known factors within the BIPOC family ties and communities that help join and help better understand each other. When it comes to faith communities, pastors are trained in mental health, first aid, become effective first aid providers in the families in their pews. When it comes to community elders and healers, traditional healers and community elders in many communities hold trust what clinical systems have to earn. Both matter. Elders in family, multi-generational households are often the first line of support, educating grandparents and parents about the signs of multiplies the number of people watching. And then we have the schools and youth workers. The adult as a youth person tells first is almost never a therapist. Coaches, teachers, and youth mentors are the first line for kids of color. All right, we have 4 steps here and 5 questions. Finding the right therapist is a search, not a lottery. Almost everyone tries more than one. This is normal and healthy. Find what works for you. Step 1, use a community-built directory. As we mentioned before, the different type of groups, and I also shared if anyone knows any other groups that you'd like to share in the chat, feel free. But we do have the therapy for Black girls, Black men, Latinx therapy, Asian mental health collective, the inclusion therapist, and nominees sharing health hope resources. Step 2, screen for it on a first call. Most therapists offer a 15-minute intro call. Ask questions on the right before booking a full session. Step 3 is confirm the cost and insurance. Ask about the sliding scale, super bills for out-of-network reimbursements, and telehealth. Do not stop at the first no, because what one provider may not offer, another one will. Step 4, give it 3 sessions. Fit becomes clearer in around session 3. If it is still not, switching is not failure. It is important consumer behavior. So just remember those 4 steps. Now we have the questions to ask on your first call. Have you worked with people of my community or background? What is your approach when clients bring up race, culture, or faith? Are you direct and structured or more open-minded? Which fits my goals? You have to ask yourself that question. What does progress look like, and how will we know it's working? And lastly, what happens if I need to cancel, if I do not feel like this is a fit? These are good starter questions to get to know a provider. So hopefully you'll be able to use that resource. All right, Fayette County is diverse and getting more so. Any conversation about BIPOC mental health only matters if it lands in the Pacific community where we live. Here's a snapshot of ours. 55.5% of Fayette County residents identify as white. This is 2024. 25.3% residents identify as Black or African American. 8.6% of residents identifying as Hispanic or Latino, and 4.9% of residents identify as Asian American. What Fayette shares with the rest of Georgia. Mental Health America's 2025 report ranks Georgia 37th of 51 for adult access to mental health care. Most Georgia counties, including several of our neighbors, are designated mental health professional shortage areas. The access gap falls hardest on families who are already navigating cost, language, transportation barriers, which is why the Mental Health Advisory Board Hub, telehealth, and community-based programs matter. And this statistic is brought to you by the U.S. Census data from Fed of 2024 and the Mental Health America, State of Mental Health in America of 2025. All right, so you may want to save this line tonight. The number 888. When the moment is now. These 6 lines together cover almost every kind of immediate crisis. All are free, all are confidential, and several are available in Spanish, ASL, and specialty for particular communities. We have 988, which you can call or text, and it's open 24/7. You can look them on the web at 988lifeline.org if you choose to. Georgia Crisis and Access Lines, also known as GCAL. The number is 1-800-715-4225. We have the Crisis Line, which is 24/7, is with trained counselors. Home, you want to text HOME, HOME, to 741-741. And to go back to the GCAL, Georgia Crisis Line, they also have an app. So based off if you have an iPhone or Android, you can put GCAL, Georgia Crisis Access Line, and it should have an app. You have the Trevor Project with the LGBTQ plus youth. It's free and confidential, 24/7. You can call, text, or chat. The number is 1-866-488-7386. Then we have the Strong Hearts Native Hotline. Sorry, not hotline. Helpline. Culturally appropriate support for Native and Indigenous callers, 7 to 10 Central Time. That number is 1-844-762-8483. Once again, that's Strong Hearts Native Helpline. Then, of course, we have the 911, and you can request an CIT trained officer. That is a crisis intervention team officer trained in mental health responses, and that's 911. For the weeks after the first call, take a screenshot of this slide, or if you're able to, if you're home, write this down. But please, if you are driving, just wait, and you can replay this once you get settled. This here is a mix of local Fed resources and community-built national directories where you can find culturally responsive care. We have the City of Fayette Mental Health Hub, which will have a local provider directory, sliding scale options, groups, and events. That's the fayette-ga.gov/MHAB as in boy, or you can visit mhab.gov. Then we have the Nomni, that's in Henry and Fayette County of Georgia. It's have free and family support groups. You can email them at henryfayette@nomniga.org. Or you can go to the website at nomnihenryfayette.org. The number is 404-668-7200. We have the Therapy for Black Girls, Therapy for Black Men. This is a directory. You can go to therapyforblackgirls.com, therapyforblackmen.org. The Latinx Therapy, Anamni Compartino Dino Esperanza, the Bilingual Therapist Directory in Spanish Education Programs, latinxtherapy.com. And then we have the Asian Mental Health Collective, is inclusion therapists, by the AAPI Focus and Multi-Marginal Focus Therapist Directory is the AsianMHC.org or InclusiveTherapist.com. And then lastly, we have the SAMHSA National Helpline. and that number is 1-888-662-4357. And the treatment referral is 24/7. And Nomni is Monday through Friday from 10 to 10 Eastern Standard Time. Or you can text Nomni, NAMI, to 6240. All right. So if you could just pick one for this week. Every action below is small enough to actually happen. Choose one that fits your role in your life this week. So for yourself, you may want to save the number 988 or GCAL on your phone. Name them so you will find them at 2 a.m. You never know who or what or when a situation may come up for yourself or someone else. For yourself especially, but for your family, have one honest check-in. Pick one relative or friend and ask, how are you really? Sit through the pause and ask again. For your community, bring one resource forward. Forward this slide or one directory link to a group, text, a small group, or church list, or a team chat. This helps in spreading awareness. Okay. So every community has a right to care that sees the whole of them. Stories change what we believe is possible. Stigma is a lock, and every honest conversation turns a key. Support is what we build for each other. One call, one referral, one Sunday at a time. Please remember this month to save 988 or GCAL, both numbers to your phone from this webinar. And this week, please share a directory with someone, whether it's therapy for Black girls, Latinx therapy, or Asian MHC to one person. Once again, this presentation is brought to you by the Mental Health Advisory Board, the City of Fayetteville. Presentation was conducted by our chairwoman, Dr. Glover. Next slide, please. Thank you all for attending and listening, for yourself and others, for showing up, for caring enough about the webinar, about the neighbors around you to sit with a topic that asks something of all of us. Please stay connected with the Mental Health Advisory Board. Our next webinar will be Tuesday, August 25th at 6 o'clock. The City Hall is located at 210 Stone Avenue West. If you have any questions, feel free to email MHAB as in boy at Fayetteville-ga.gov at any time. Thank you all. Hope that you have a good evening.